Hello everyone, I can see that people are still joining, so we're just going to give it a couple more minutes before we kick off, if that's okay. So before we start with the slides, I thought I would just do a quick round of introductions for the people that are presenting today. But first off, thank you to everybody that has joined. My name is Polly Edmonds and I'm a consultant in London and chair of the Palliative Medicine Specialist Advisory Committee at the PTB. I'm going to just ask a few people to very quickly introduce themselves. Alistair, can you go next?
Yeah, thanks, Polly. I'm Alistair Miller. I'm a consultant in infectious diseases and general medicine, and I'm the Deputy Medical Director of the Joint Royal College of Physicians Training Board that has overall responsibility for the 30 curricula for physician postgraduate training, and I chaired the Curriculum Development Committee that wrote most of these new curricula, obviously with the major input from the individual SACs. Thank you.
Thank you. And Vicky?
I'm Vicky Young. I'm Curriculum Assessment Officer at PTB and have assisted the SAC in doing the sort of formal applications via the GMC.
Thanks, Vicky. Sam?
Hi, I'm Sam Chermateng. I'm a consultant in Palliative Medicine in Sheffield, and I'm the Training Programme Director for Yorkshire and Humber.
And Matt?
Hi, I'm Matt Carey. I'm Training Programme Director and Consultant in Oxford.
Jane?
Hi, I'm Jane Nick and I'm a palliative care consultant at University College Hospital London and was the TPD for London.
And Milind?
Hi everyone, I'm Melinda Rolker, consultant physician with Heartlands Hospital Supportive and Palliative Care team in Birmingham, and I'm the Training Programme Director for West Midlands.
Thank you. So I was just going to kick off today, and we're delighted to see so many of you here. This curriculum has been a long time in the making, and you know, obviously what we want to do today is just kind of give you Next slide, please, Vicky. Just some housekeeping. If people could please turn their cameras off and mute their microphones, it just helps then we don't get any background noise that way. Please, can you write your questions in the chat? Matt is going to be keeping an eye on the chat and he's going to be kind of trying to collate themes and specific questions, and we're going to take all of the questions at the end. So we're going to run through all of the presentations one after the other, and then take questions at the end. But because we're keeping an eye on the chat, please do feel free to write questions as they pop into your head. Next slide, please. So I'm just going to run through a bit of a background to where we are with the curriculum, and talk to you about the new capabilities in practice. Jane is going to talk through some of the changes to assessments in the e-portfolio. Milind is going to talk a bit about the transition to the new curriculum and the interface with internal medicine. And then Sam's going to sort of host, if you like, 4 trainees who are talking about their experiences already dual accrediting on the curriculum. So to give you a bit of background, this is kind of like our kind of timeline. So where we got to started with the 2013 Shape of Training report, which recommended that specialties across the board moved to more generalist and broad-based training to better meet the needs of changing population. So with increasing older people, multiple long-term conditions and so on. And the college, working together with the UK Shape of Training Steerage Group, recommended that palliative medicine become a Group 1 specialty, which means that we will in future be dual training with internal medicine. And we have been developing our curriculum along those lines for some years. It was finally formally approved by the GMC Oversight Group in March of this year, and will start in August. So I think it's the 2nd of August 2022 is when the new curriculum goes live. One of the major changes is that all of our applicants will need to have come through internal medicine, which is a 3-year training pathway. There's then a point of selection into specialty training, and that is an indicative period of 4 years for palliative medicine. And that will be including a year of internal medicine integrated into the specialty training. And that will lead to then the award of CCT. So we have a 4-year programme. We've tried to rebalance and change the curriculum to recognise changing population needs. So we've got much more in the curriculum now about frailty, about multiple long-term conditions, about the ageing population, organ failure, supportive care in cancer and transition services, to give you an example. So there's lots of stuff in there that you will recognise, but there's also lots of stuff that perhaps has become more important over the last 10 years that we have put into this new curriculum. We have an indicative minimum time recommendation of 6 months in all of the 3 different care settings in which we anticipate trainees will train and then work, so community, hospital and inpatient. But this is a minimum. It's not, so it will be very much individualised as to how much time different trainees will spend in different settings. But this gives us the flexibility to try and tailor training to different trainees. We've also put in more detail about what we're expecting from trainees in terms of meeting capabilities. And so specifically, we've tried to really flesh out about what we're really looking for from a learning perspective when doctors are involved in specialty take and on call, for example, and working in the different palliative care settings. So what are the knowledge, skills and attitudes they may get from those clinical components of the curriculum? There's much more focus on public health in palliative care. There's a recognition that things have changed, particularly on the back of COVID, in relation to technology and remote assessments. And we've also tried to build in a recognition that for all of us to have sustainable careers, self-care and resilience is really important. Just a word about public health. What we have tried to do in the new curriculum is represent more modern thinking about public health and palliative care. So shifting away from a more sort of narrow biomedical model of public health to really being able to understand and explore more contemporary themes about health promotion and compassionate communities at the end of life. So we've done this both by a section in the syllabus that really outlines why we think it's important for our consultants of tomorrow to have better understanding about the opportunities that better community engagement give us. But also we've also woven the theme, if you like, through the descriptors that accompany the capabilities in practice. And there's just some examples are given on this slide. I'm very aware, and I think the SAC is as well, is that this is not an area where many of us are particularly skilled or comfortable. So we're very lucky that our public health colleagues are setting up several training programs. So there's one that's specifically going to be geared at doctors in training, but another one that any doctors interested can apply to. So this is going to be a mix of webinars, a formal study day and a workshop looking at compassionate community skills in the clinical setting. So Julian Abel and colleagues are going to be running those, and we've already sent out some links for how people can book on to the training that is now available. What has not changed? So we've still got a curriculum that asks our doctors to train across all different palliative care settings. It's still a very broad approach to training, so very much thinking about holistic palliative care approach based on need, not diagnosis, and underpinning our knowledge and skills with detailed assessment, knowledge of pharmacology, and excellent communication skills. This curriculum will allow us still to be flexible in meeting individual trainee needs, and there's no reason why that can't include applications for less than full-time training or out-of-programme experience or academic training. We have also the basic assessments that we've got that support learning are the same. We have added in some new ones that Jane will talk about, and we've tried to be pragmatic in terms of our use of the DOPS to make it more geared around learning. And the palliative medicine SCE will continue, and for those that are going to ask, there isn't an SCE for internal medicine, so it's just the one SCE that trainees will need to do. So one of the really big changes is that we're moving away from a competence-based curriculum to one based on capabilities in practice. And so we all need to kind of make quite a big shift in terms of how we think about supporting doctors in training and then with their learning and then with the assessment. So what are capabilities in practice? Well, they describe the professional tasks or work within the scope of a curriculum and are based on the format of what are called entrustable professional activities. So they ask us as supervisors to utilise judgment as to whether or not a trainee, the level of supervision that a doctor in training is needed to undertake that task. So you would go from somebody who's needing full supervision to undertake a designated task to the doctor by the end of their training being able to complete that task completely unsupervised. And at the end of training, doctors will need to be able to demonstrate that they're capable of unsupervised practice across all of the SIPs that are in the curriculum. So each capability in practice is then broken down into a series of descriptors. This is just an example that's shown here. I appreciate it's very small and you won't be able to read it, but don't worry about that. And the descriptors help give examples of the types of learning that a trainee may undertake in order to meet that SIP. They also, the SIP in the curriculum will give the expected level of performance, and it also talks about how it's mapped to the GMC's General Professional Capabilities Framework. And it outlines what evidence a doctor in training may produce for a trainer to then assess their capability for that SIP. So just to talk about that in more detail, the descriptors each SIP will have a list of descriptors associated with that activity or task. So they're giving us a guide as to the minimum level of knowledge, skills and attitudes that should be demonstrated by the trainee. And obviously it ultimately moving towards the doctor in training being independent of that SIP. But they are not a comprehensive list. So it's not about going through every single word and line of the SIP and ticking them all off. They're examples that guide you as an assessor or a trainee as to what they need to do to support evidence that for that SIP. So it's really important that we don't think about the descriptors as the competence framework that we've had in the past. It's more high level than that, but it's a guide to the types of things that we are expecting. The SIPs are grouped into 3 categories. So each of the medicine curriculum has a series of generic SIPs. The internal medicine has its own SIPs, and then palliative medicine, our curriculum, has its own SIPs. And I think the easiest way to think about this is of the curriculum as a matrix. So all of these 3 bits fit together. So some of you may have been involved in the consultation we did on the new curriculum and will remember that you won't have been able to easily see stuff about research or stuff about education and training, for example, and that's because it sits within the generic SIPs. So we have to think about all of these different SIPs meshing together, and a doctor completing training will need to demonstrate that they are acting unsupervised across all of these different SIPs. So just to, and then it's all underpinned by the GMC General Professional Capabilities Framework, which you can see here. So just to remind you what the SIPs are, so these are the generic SIPs, so you can see that skills around communication, research and teaching are all represented through the generic SIP. So we haven't, so our specialty curriculum builds on these but doesn't duplicate them. And the same is true for the internal medicine curriculum. So these are the internal medicine SIPs, and some of you will be familiar with this already, supporting IM trainees in how they achieve SIP 8, which is around palliative and end-of-life care. But this these IM SIPs run through into stage 2 of the IM curriculum, and our trainees will obviously need to demonstrate by the end of training that they are independent across all of these 8 SIPs. And the same again then for our specialty SIPs, of which there are 7, and that you can see them here on this screen. So these hopefully encompass the range of palliative medicine practice that we are envisaging a doctor completing training will be independent in by the time that they CCT. This is just an example of a palliative medicine SIP. It's a bit bigger, so hopefully you can see it. So this is the one that's talking about managing complex pain. So you can see that there's a range of descriptors that are underpinning that SIP. So they're describing, as I said, a minimum level of knowledge that we would expect for a trainee. And we would expect to see a trainee progressing from needing supervision to being independent in relation to this SIP. We then look at the next slide. This gives us the links to the general professional capability framework and what sort of evidence a doctor may produce in order to inform the decisions about where they are in relation to that SIP and the rating of that SIP. And I'll hand over to Jane because she'll be able to talk you through a little bit more about how that's actually going to work when you're in the portfolio. Thank you, Jane.
Thank you, Polly. So I think, as Polly says, trainees will need to use a kind of combination of evidence to meet each descriptor, and that's going to include the workplace-based assessments. So there's going to be a range of workplace-based assessments that can be used to inform and sign off decisions about trainees' experience. And I think it's really important as an assessor, as a clinical supervisor, an educational supervisor, that the assessor that's carrying out a supervised learning event are making accountable professional judgments about the trainee's knowledge and performance. And this is about moving to, rather than a tick box exercise, to a holistic decision about a trainee's progression. They don't need a specific number of workplace-based assessments per SIP. It's going to be based on clinical judgment and observing the trainee in the workplace as well. So there is a whole variety of workplace-based assessments. Some of these you're very familiar with, and some of them you'll notice are newer or new to you. So things like the ACAT, the Acute Care Assessment Tool, some of you may well have used, but it hasn't been compulsory previously for trainees to do ACATs. It's just been something that we've recommended. And what we're now doing is asking that all trainees do at least one ACAT a year. And the aim really is for them to be observed whilst they're on call or on a ward round. And seeing at least 5 cases during that time that then are discussed afterwards. The new assessment is something called the leader tool, and that's an opportunity really to assess a trainee's leadership development. So it looks at a variety of different domains, and this is something that was originally produced by the Royal College of Paediatricians and has been used in the paediatrics curriculum for quite a while. We trialled it in London and I think one other region a couple of years ago for the trainees to see how they felt, whether it was useful, whether or not it gave them constructive feedback, and we got very good feedback from the trainees and from supervisors who found it very useful to use it. It looks at leadership within a team, how effective the trainee is, how good they are at acting within a team. It gives them the opportunity to set some direction. It enables improvement and also to reflect on specific leadership areas. And again, that's something that within the ARCP document, they're supposed to do one earlier on in training and then one later on in training, which shows that there's some progression and development within their leadership. The next one is a patient survey. I think most people will be familiar about a patient survey, and it's never been required by palliative care trainees before, although it is on their educational supervisor report, but it's always ticked as not required. It's felt that all consultants for revalidation need to do a patient survey, and so we thought that this was a very important part for trainees. we recognise that it's always difficult for any doctor in palliative medicine to get feedback. So we recommend that trainees only need to do one of these in the 4 years of training, but to try and start doing it very early. And then there's no longer an audit assessment or a QIPAT. It's moved to being a QIPAT only, which is the Quality Improvement Project Assessment Tool. The other one that I've highlighted here is the Educational Supervisor Report, and that's something that's always been done, as has a multiple consultant report, but there's some changes to both of those, which we'll discuss next. So on this slide, it's just showing the minimum number of workplace-based assessments that trainees will need to do over the 4 years of training. The numbers overall have decreased. So, for example, with the CBDs or mini KECs, in ST4 trainees now only need to do 6 of those altogether, whereas previously it was 6 KECs and I think 4 CBDs. So that's just, and there's no longer the top 20 topics or top 10 topics that they need to cover either. So I think, as Polly mentioned as well, there's quite significant changes to DOPS. It's about trainees being comfortable and competent to recognise issues that may arise with regards to certain procedures. So trainees will all need to be able to set up a syringe driver, both in a skills lab and in real time as well. And the curriculum states that a total of 3 syringe drivers need to be done during their training to make sure that they maintain competence. There are a few DOPs that have come out that you may recognise. There is no longer paracentesis in there. There's no longer TENS machine or PIC or Hickman lines. Some of these we've taken out altogether. Some of them, such as paracentesis, has moved into the IMT part of the curriculum. We felt that it was important that things like spinal lines, NIV and tracheostomy care stay in the curriculum, but it's moved to ensuring that trainees are competent in a simulated setting. So they don't have to necessarily do this with patients, but that they have to be competent in a simulated setting. And the last one that's completely new is around managing indwelling pleural and peritoneal catheters. That was felt when writing the curriculum. This is something that's much more routinely used now for patients. And again, that's about being able to be competent to manage any complications, advise patients, referring patients into community teams, and what needs to be done with regards to those things. So there's much more simulation with regards to DOPS, and so there has been a programme that's been developed in London as a formative development day, which has had excellent feedback. There isn't been discussion about scaling that up and being able to have regional hubs, having local simulation days for trainees to go to. And there's a lot of funding at the moment in HEE for simulation. And it may be that certain STCs may have a simulation lead as well. So at the moment, most of the simulation that is in the curriculum is around the DOPS, but there may well be simulation for human factors and communication skills being developed in the future as well. So the next thing is the e-portfolio. So there's going to be quite a few changes really onto the e-portfolio that supervisors and trainees will need to become familiar with. So for all the trainees that are transitioning to the new palliative medicine curriculum, their old e-portfolio won't transfer to the new e-portfolio, so it will run alongside it. And so part of the role of both the trainee and the educational supervisor, when they start to work on the new curriculum is also trying to remap what they've done previously and pull in certain things and make comments on what has already been achieved elsewhere. Trainees will, on the new curriculum, will have 2 curricula running side by side, which will be their IMT and their internal medicine and their palliative medicine curriculum. And as Polly mentioned, is that the curriculum will be mapped to the SIPs. What's really important at the moment, things happen differently around the country, but trainees will need to self-rate each area and link items to justify their rating for each SIP. So a lot of trainees will do a lot of linking, but they don't always self-rate their curriculum. They allow the educational supervisor, when they meet them, to rate their curriculum and decide whether or not they've met it or not. What's really important with the new curriculum is that trainees are going to have to self-rate each area. The educational supervisor will then review the trainee self-rating, look at a range of evidence and their multiple consultant report for each SIP, and then provide a rating of their own. So the new curriculum is SIP-based, and the SIP will be grouped and appear on the curriculum page of the portfolio. So it will look a little bit like this. There will be different SIPs running alongside. So you'll have the generic SIP, the internal medicine SIP, then the specialty capabilities in practice SIP. And it's really important because as a supervisor, you won't just be signing off the specialty capabilities in practice, but you will also be signing off some of the generic capabilities in practice too, whether that's with research or education. And it may be that there are certain parts of the internal medicine, for example, SIP 8 of the internal medicine is about end-of-life care and palliative care. I think SIP 5 is about working in a multidisciplinary team and effective discharge planning. So there's links that you may not just be signing off one curricula, one part of the matrix curricula. So trainees will get ratings for generic SIPs, whether they are below expectation, meets expectation, or above expectation. But for the specialty SIPs, they will be more at different levels, from level 1 to level 4. Level 1 is below training. Level 4 is at a level that they are competent to complete their curriculum. And then there are ratings for the practical procedures, so for the DOPS, about whether they're unable to perform the procedure up to competent to perform the procedure unsupervised, which is the level that trainees need to be at to be signed off completely. And then, of course, that they maintain that competence throughout their training. So there's a few changes to the multiple consultant report, but this form is designed to help capture the opinions of consultants who have supervised the trainees in a clinical setting. So it doesn't necessarily only have to be a palliative medicine consultant, but it may be consultants around the hospital in different specialties as well. And the multiple consultant report is split into the specialty specific SIPs, and then the respondents provide feedback on the trainees' progress against each of these SIPs. So some supervisors or some consultants that are asked to feedback won't necessarily be able to feedback on every single SIP. You know, it may be that consultant hasn't observed, for example, SIP 6, which is to manage the delivery of holistic psychosocial care with regard to grief and loss. So it may be that they just don't put a comment for that one. So, but the aim is that there will be several multiple consultant reports, and so that will give an overarching view on the trainee, and then they're collated and summarised in the summary sheet. So this is an example of a multiple consultant report which will be specific to each specialty. There will be, so this is around the geriatric medicine, but clinical supervisors will record their rating for each SIP, and they only record the feedback for the SIPs that they've observed. So then there's quite a few changes to the educational supervisors report, and this has been designed for each specialty, and there will be a different ES report for internal medicine. What's really important is that the rest of the curriculum and the other reports need to be done before the educational supervisor report is done, because the ES report auto-populates all the latest ratings and comments made by the educational supervisor from the curriculum page. So if the curriculum has not been updated, then nothing will come through onto the ES report, and the ES report cannot be changed in the ES report. So the educational supervisor rates and comments the trainee's progression on the curriculum page, and then this gets pulled through into the ES report like this. And here there are two ratings, because different things have been made by the reports have been made by the educational supervisor, and the system will check the latest rating that was made, and that will be populated in the educational supervisor report. So that will be continued to be updated. So if for example, you do some parts of the curriculum in the January and then you do more in the July, it will pull through both the January and the July comments. When the ESR is created, the SIP ratings and comments also auto-populate. And you can save this. This will be saved as a draft throughout, and then so long as it's saved as a draft, it will continue to update itself until it's saved as a final, which is usually done just before the ARCPs. And then there's also something called a summary of progression page. Lots of trainees have had to do this themselves, which is kind of highlight where they're up to with the number of workplace-based assessments that they've done, but this will automatically do it for them. It will be organised in sections that reflect the ARCP decision aid and auto-populate and display the latest data. And this will really help kind of educational supervisors, but also the ARCP panels to know where trainees are up to. And we'll look at a little bit like this. So it will just pull all the numbers that have been done. So each section will auto-populate data if evidence has been recorded in the e-portfolio as well. And where there's a specific indicative target, it will also turn green, so to show that it's been met. So I think that's also quite helpful for ARCPs. Now we're going to move on to transition of the current trainees. So there are an awful lot of trainees that are currently on the old curriculum. So those who started training prior to August 2021 are encouraged to transition unless they're in their final year, but are not required to do so. Now, all trainees will have been asked this already. This isn't something new. This is not new information to them. Supervisors don't need to panic that they haven't had a discussion with their trainees. This will be something that's already been discussed by their TPDs. If they are staying on the 2010 curriculum, which the majority of them are, they will fill out a form within their e-portfolio, and it will be confirmed by their training programme director as part of the ARCP process. So even if they're working part-time or they go off and do some research, they will be able to stay on the old curriculum. Those registrars that started training after last August, so after August 2021, and those that have been appointed since then, are mandated to transition unless they come from a general practice or other non-CMT background, they have exceptional personal circumstances, or there are patient safety concerns if they were to transition, and that's usually around the fact that they may not have done any general medicine for 5 or 6 years, and to go back to do it may just be too difficult. those trainees that are not going to that fall under the mandatory transition but are not transitioning, it has to be approved by the postgraduate dean themselves that they don't need to transition. For those that do have to transition, I guess what has been done already and what needs to be done. So trainees will all have met with their TPDs, and something called a gap analysis will have been done. And that basically looks at what have they missed out on doing in both IM training and possibly palliative medicine training that they need to do to get to where they should be if they were an ST4. So they may not have done any of their IMT3. They may therefore not be able to manage an acute unselected take as at the level of a registrar, or they might not have had critical care training, which is part of the new IMT curriculum. So they may have to go and spend some time doing that. So it may be that trainees that are transitioning will have to go out of the palliative medicine programme to fill those parts in. Those that have been part of the palliative medicine curriculum for a year already may have missed out on some of their IM stage 2 time, so they may need to catch up on some of that. So they may just need to spend a bit more time in their doing IM. The ES's role really is supporting the trainee as they transition, to help them with the evidence on the old and the new curriculum. So kind of moving that portfolio over into, because that won't be done automatically. And just to be aware that the CCT date of the trainees may change, as they may actually need some more time, and that will be agreed in their ARCP. So I'm now going to hand over to Milind, who's going to discuss a little bit more about the interface between IM and specialty training.
Thank you, Jane. I hope you can all hear me. Before we talk about the interface, if I show you the next slide, this gives you two examples of how this new dual curriculum is going to be implemented. I've got two examples here, a top row and bottom row. Bearing in mind that the dual training should involve a broad range of specialist settings, plus IM stage 2 experience in acute trusts. And I've got here two examples of a sort of block approach from two different deaneries. And I speak for probably all of my training programme director colleagues. These are the work that has gone into thinking about how to implement the dual training curriculum has been enormous, and I thank all the STCs up and down the regions in thinking how to make this work for the trainees. So on the top row, you can see that entry into dual training after completing stage 1 IM training, so years 1, 2 and 3, they would then be recruited and successfully appointed, and then enter the first year of a full year of inpatient hospice setting ST4, and then in the second year 4 months of stage 2 IM training with 8 months of hospital or community focused palliative medicine training. ST6 year, 4 months of stage 2 IM training in an acute trust, followed by 8 months of hospital or community focused PALMed training. And then final year, another 4 months of stage 2 IM training in an acute trust, followed by 8 months of palliative medicine inpatient hospice setting. That's just one way of trying to implement this. On the second row, we've got another approach from another deanery. So after competitive entry into ST4, you have 1 year of palliative medicine inpatient hospice setting, and then the deanery I'm quoting here has opted for, in ST5, 6 months of stage 2 IM training in an acute trust and 6 months of hospital palliative medicine training. And then in the ST6 year, 12 months of community training and senior hospice palliative medicine training. And then internal medicine reappears in the final year for a 6-month block, followed by 6 months hospice or hospital palliative medicine training. So the ask up and down the country is to think about how to fit internal medicine alongside specialty training. And it's worth saying that there's no particular right way, no particular wrong way. It really reflects local service arrangements, local relationships with acute trusts, and what works for the particular STC that colleagues are used to delivering. The other thing I'd probably say, sorry, go back a slide, it probably creates a false impression that the two curricula are mutually exclusive, and they're not really. We should be encouraging our trainees to think about mutually compatible opportunities, irrespective of the block they're in, so that they robustly dual train and develop independence in the capabilities required for GIM and PalMed. And you heard Jane and Polly talk about this idea of a matrix curriculum. So I'll develop this idea on the next slide. Thanks very much. Next slide. So our IM training post should provide trainees with perspectives on patient management delivered in other medical specialties. And the generic and IM capabilities can be acquired during specialty training, with us in hospice, community or hospital, and placements labelled as internal medicine. And a point worth highlighting in terms of this matrix idea is that up to 3 months of palliative medicine can count towards acquisition of IM capabilities. Next slide. So if you cast your mind back to the IM curriculum, I've got here capability in practice number 5, managing medical problems in patients in other specialties and special cases. Well, if you think about this, you could easily help a trainee develop this capability even within the specialist setting. So if you go to the next slide for me. So our trainees will develop effective consultation skills, including in challenging circumstances. They'll be managing medical problems for inpatients under the care of other specialties, and they'll demonstrate appropriate and timely liaison with other medical specialty services when required. So the trainee is hitting both bits of the curriculum irrespective of the block. Next slide, please. Here's another example, IM SIP 6, managing a multidisciplinary team, including effective discharge planning. So this SIP is about ensuring continuity and coordination of patient care through the appropriate transfer of information, demonstrating safe and effective handover, estimating length of stay and identifying appropriate discharge planning, delivering patient-centered care, including shared decision-making, and recognising the importance of prompt and accurate information sharing with the primary care team following hospital discharge or specialist palliative care unit discharge. So this is on black and white, appears in the IM curriculum, but you can see how it cross-fertilises very nicely with specialty training in palliative medicine. Next slide. So some further principles of dual training, that there needs to be separate educational supervision and GIM representation at ARCP, and that's regarded as the gold standard. What this will look like locally in your area is to be confirmed and to be announced, and those ARCPs will happen next year. Eventually, we'll start to produce trainers who are comfortable with supervision of both internal medicine and specialty curricula, but for the time being, clearly the cohort of trainers now are only going to really robustly train for the specialty. But you will recall what Jane said about aspects of the matrix curriculum that you can reasonably comment on and give feedback on, even though those capabilities will exist in the other bits of the curriculum, IM and the generic parts of the curriculum. A question that probably will arise in this block approach is how do we encourage our trainees to keep in touch whilst they're away from specialist palliative medicine training sites? So training programme directors ought to work with training units and trainees to facilitate a concept of trying to keep in touch with training. For example, thinking about palliative medicine whilst in their IM post, and thinking about internal medicine training when they're in their specialty palliative medicine post. So this may take a local format of specialty and IM training days, irrespective of the block in which the trainee is in. Perhaps undergoing procedural skills simulation as a refresher, irrespective of the block they're training in. Thinking about acute take, AMU, and same-day emergency care sessions. And then any outpatient or community experience outside of specialty training, palliative medicine, that is very useful for the trainee to experience. Next slide. Okay, so I need to hand over to Sam, I think, for this section.
Hi, Mel. Thanks very much. So I think we recognise that training we're just embarking really on the implementation of the new curriculum, and so there's going to be a lot of iteration and a lot of learning as we move forward within the new curriculum that's just about to be started.
Sorry,
we're just challenging you, Vicky.
I know, it's like, that's not my slides. Can we all see that again?
Hi, I'm Emily, Palliative Medicine ST3.
Are you seeing these slides?
Yeah,
Emily?
Yeah, we can see the slides. So essentially, so we've got Emily, Catherine, Rose and Stephanie who are going to give you some video vignettes really of their experiences. It's really important to note that this is really just an approximation of what dual training will be. This is really us picking up on the experiences that we've learned from in the transition process. And so there are some real positives that we can build on and some challenges which we're addressing and considering in this next round. I think these challenges are not unique. And I think they're recognised in conversations across the SAC that we are addressing as part of the implementation. So if you're happy, Vicky, if you could start the video for Emily. Thank you.
In Yorkshire. My experience so far as a dual trainee has been 2 months spent in ICU as part of the transition between CMT and ST3. I learned a lot from the ICU team in terms of managing sick and deteriorating patients appropriate for escalation. And I noticed a surprising amount of crossover between caring for palliative care and intensive care patients. I felt that I could also contribute to their team by making suggestions about symptom management and supporting the difficult conversations, particularly around withdrawal of care and when reviewing patients deemed unsuitable for ICU. And I felt that the sharing of knowledge that I experienced would be equally valuable in all ward environments. I did, however, feel that I was seen as the palliative care registrar in ICU rather than a dual trainee, which meant that I was directed to reviewing palliative patients rather than getting to experience or getting opportunities in acute medicine or intensive care. I think this is likely to be a symptom of transition, but felt that this highlighted the importance that our general medicine supervisors need to be fully informed about our focus and competencies when on medicine blocks. I've got particular interest in improving access to palliative care for patients living with non-malignant life-limiting illnesses, and think that dual training will not only help me to improve my knowledge about managing these patients and the symptoms and complications of their conditions, but that having palliative trainees within medicine will increase referrals to specialist palliative care.
So just as you can see, Emily came into palliative medicine prior transition after having done a CT3 year effectively, and in which she gained additional experience in elderly care and community geriatrics, as well as working as a specialty doctor. I think Emily's appeared on her camera there just now, and so I think the trainees will also be available to give some responses when we do the question and answers section later on. And that was addressed in the 10-week placement, and it's that experience that's allowed Emily to articulate the challenges. There was one thing particularly here that she commented on, and something that we're focusing on about how we can enable GIM placement supervisors and clinical supervisors to ensure that our palliative medicine trainees are not in that setting just seen as palliative care doctors. That it's not an only thing. We want them to gain optimal experiences across GIM, as well as the experiences that we can bring to bear in specialty training. Do we have the next slide, please? That's great. So now we've got Catherine, who's going to give us a little bit of her different experience, and it highlighted to us some of the specific challenge around on-call rotas, which we've been very aware with and keeping in touch. If you're happy to play the video.
Hi, my name is Catherine and I'm a Palliative Medicine ST3 working in South Yorkshire. Overall, I think that dual training will be beneficial to palliative trainees and I support the change in the curriculum. But today I wanted to use this platform to highlight a couple of concerns about the implementation of the new curriculum that have affected me so far. Firstly, I personally prefer to have medicine and palliative integrated in our work schedule at the same time, rather than in separate blocks. I feel working several months in palliative with no acute medicine on calls will result in a lack of confidence in my acute medicine knowledge and vice versa. I believe a system where a few acute medicine on calls are required during the palliative blocks and several palliative on calls are required during the acute medicine blocks would be beneficial, as this would keep my exposure and confidence up in both areas. A further concern relates to on-call teams not knowing who we are and being additional to the on-call rota. Currently, I am working a 4-month rotation in ICU with medical night shifts. I was informed that the medical night shifts would be SHO level, which involved clerking the acutely unwell patients in AMU. I was happy about this arrangement as I didn't feel confident to act as a medical registrar during my first set of nights in a new trust, with nearly 2 years away from general medicine. When I arrived for the shifts, nobody was expecting me, and because I was an additional member of the team, I was asked to cover for an F1 who had called in sick. This meant my night shifts consisted of acting as F1 ward cover. I fully appreciate that when the team is a member down and I am seen as additional to the numbers, that covering the sick colleague is required. However, I'm concerned about how covering for junior members of the team is going to result in a lack of training opportunities for myself and others in my position. I believe the rota coordinators are unsure of our role within medicine, and that has impacted my exposure to acute medicine, which is essential in order to build confidence before becoming a medical registrar. Thank you.
So Catherine's period of transition highlighted some complex issues there that she's articulated. In terms of keeping in touch days, I think as TPDs, we were all slightly challenged when we recognised that we needed to produce keeping in touch days both ways for our trainees in acute medicine when they are our trainees when they're in the acute medicine blocks back into palliative medicine, and clearly when they're in palliative medicine blocks into the acute phase. But what's really clear from Catherine's description of her experience, and you'll hear something from Stephanie a little later on, you can see that that's going to be a critical component of ensuring that that training meets their individual requirements, and it's something that we've addressed through some of the changes that we're implementing with the launch of the new curriculum. Next slide, please. I think it's also just worth noting that also it really requires us to pay special attention to on-call commitments to make sure that our trainees are getting optimal training experience, and this is something that we obviously have to pay very careful attention to. And in other parts of our Yorkshire rotation, we've been really clear in making sure that that the registrars get registrar level experience. So just something that we're aware of. So this is Rose, who has come to the CMT route and gained additional experience, as you can see here. And her requirement in closing the gap was to spend some time on as the acute medical registrar.
Hi, my name's Rose. I'm also a palliative care ST3 in Yorkshire, and today I'm adding my own experience and thoughts about dual training to those of the other registrars. To make sure I met the competencies of the new curriculum, over the past year I have worked on the acute medical take as the medical registrar. Whilst there, I developed knowledge and skills that have been very helpful in my role as a palliative care registrar and vice versa, and I do think my overall abilities as a doctor are enhanced by dual training. I have noticed a couple of things during this past year that I thought would be worth mentioning. Firstly, one of the main attractions of palliative care for myself was the different settings: hospice, community and hospital. I wonder, with this new role, whether the focus is a bit too much on hospital medicine, when that's not necessarily where we'll be working as consultants. I suppose I worry that I could complete my training with a mindset skewed towards this setting, which may not always be applicable to my role later on. On a more day-to-day level, the level of senior advice and support provided in palliative care is very different to that provided in acute medicine. In palliative care, as an ST3, I'm used to consultant input regularly and a general expectation that I'll be contacting a senior, especially during on-calls. In acute, the ST3 is generally looked to as the most senior doctor on shift, and this, although appropriate for the speciality, can almost come as a bit of a culture shock. I suspect this will get easier to manage as I gain more experience in both specialities, but it definitely took some adjustment initially. Thank you. I hope this was helpful.
Thanks, Rose. And now, what Rose has articulated there is something again that we were aware of in some of the challenges that our trainees are going to face as they move from one curriculum to the other, and also from one setting to the other. I think that it's very clear in the development of the curriculum the requirements for minimum indicative time, but it is minimum indicative time. And I think we're very confident in Yorkshire that what we can do is we can address and ensure that our trainees, when in their palliative medicine placements, can have a positive experience in the way that they've always have. I think in terms of the culture change, I think that's a new challenge that we recognise for our trainees in switching gears between acute medicine and between palliative care. And that's something that we know, we recognise, we can see ahead of time, and that we're considering how we could respond to that. And I think Stephanie will articulate that in the next video.
Hi, my name.
So Stephanie is one of our, again, she's come through the acute common STEM training straight into ST3, but is also one of our academic clinical fellows in Yorkshire and Humber. So has a additional set of unique challenges that she has to face in this process.
And I'm also one of the ST3s in palliative medicine in Yorkshire. I'm also an academic ACF trainee. I'm going to add my thoughts on the positives and some challenges that have come in my experience from dual training so far. So I did acute care common STEM training instead of CMT, and have now moved into ST3 palliative care this year, which meant that my gap in the curriculum was to act up as medical registrar. So I have been spending some time with the general medical team and acute medical team in Leeds to fill that gap. So overall, I found it a very positive experience. I think that we can all learn from each other. As Emily said, we can bring some of our palliative knowledge to the other medical specialties, as we would learn from other specialty registrars on the take as well. I think working in general medicine gives us a better overview of how the hospital works as a whole, which is really important when thinking about patient care, especially about moving them around the hospital. I personally enjoy dual training. It's more dynamic. I find it very interesting. I have an interest in acute palliative care, and so I'm really grateful to have the opportunity. I think it means that we will be upskilled in our medical knowledge, which can then be really helpful when we are working in purely palliative care settings, and we can help to upskill our colleagues around us. Some of the difficulties I've found, the pace of work and thinking is very different between acute medicine and palliative medicine, and switching mindset between that faster and slower pace does take a lot of work, and it's something that I noticed having worked in acute medicine before going into my hospice placement. I had to really slow myself down, and then I've had to do the reverse going back into acute medicine. I also have noticed that I will be worried that I am perhaps have a tendency to be going for more less invasive treatments, or maybe even more invasive treatments to overcompensate. And this is an interesting reflection that I had, and it has been echoed with some of my colleagues as well, that as a palliative doctor, people have certain views or expectations of us perhaps, and I find myself very aware of that when I'm looking after medical patients, especially those who would be for full treatment, to sort of overcome that pre-expectation, I guess, from my colleagues. I have, as an academic trainee, found it quite difficult to balance the time between medicine, palliative training and my academic training, and have had some issues when trying to voice my concerns with that and trying to make sure that I still get my 25% academic time. It has worked out, but it has been hard work to try and get everybody understanding the needs for my training in such an uncertain time, and I think that reflects the uncertainty of what we're all going through just now. My final reflection has been of late, after doing almost 3 months in acute medicine and not palliative care, I've noticed a drop in my job satisfaction, and I think that's really important for us. We went into our training wanting to be palliative doctors, and for me that is where I get the most satisfaction. And so I would echo what Catherine said, that not only for our competencies to be maintained, but also for our job satisfaction and general well-being, that having a mix of the two specialties together as opposed to blocks where we are a long while away from doing what we've always wanted to do would be preferable for me. I hope that was helpful.
So that's the end of the vignettes, and I think what you can see, it's not an entirely varnished account of people's experience, acknowledging that that is part of transition, so it's not exactly what we're going for. But what we've done is we've learned a great deal from the experiences, and I think thinking about some of the last comments that Stephanie made in terms of the experience of blocks and how we can weave palliative medicine through the IM blocks, that's something that we've been considering very carefully as we go along, and we look forward to addressing from August onwards. Thank you.
And I'm also one.
Thank you, Sam. And I just wanted to obviously thank the four Yorkshire and Humber trainees for giving us such constructive feedback and insight. I just wanted to just finish the presentation with just a few final thoughts to try and pull this all together. If I can have the next slide, Vicky. So just to obviously highlight, as you all know, this is a very major curriculum change. You know, we've never done this before in terms of dual training. It starts in August, and we're going to have to really shift our mindset away from detailed competence-based assessment into the SIPs. And I think it is really helpful for us to just think about how the generic SIPs, the IM, palliative medicine and the GPC framework all kind of fit together. It's not going to be that easy for those of us that are supervising trainees, because we're going to need to run both the 2010 and the 2022 curricula, which are very different in parallel. But we are committed to monitoring the impact of the implementation of such a different curriculum. So we've trialled a survey to training units, I think it was at the end of last year. We just need to tweak that, and we'll be doing that again. We'll repeat that survey this coming autumn. And we've also developed with the trainees committee of the APM a survey specifically for looking at the experiences of all trainees, so including those that are not moving to the new curriculum, just so that we can monitor the impact. I would, for those of you that are either doctors in training or training supervisors, of course, this is not going to be completely and utterly smooth and straightforward. We're going to come across things that we're not necessarily expecting. So we would ask you to escalate any issues, concerns or problems to your local training programme director as soon as possible, while we can still address and fix things before they become a major issue. So good luck to everybody. What I would like to do now is just open the floor to questions. So I think Matt has been keeping an eye on the chat, and I don't know whether you want to start, Matt, by sort of addressing specific questions to members that have been presenting today, but please do all continue to put questions in the chat so that we can make this section as interactive as possible. Thank you.
Brilliant. Thank you ever so much, Polly, and everyone just presenting there on the panel. There have been a few questions that have come up in the chat, and I think it'd be really good to post them to the panel to get some thoughts and discussion going. First one, which was asked quite early on, about the speciality certificate exam, and there's a couple of questions on that. And I guess it's taking into account the fact that we are transitioning to a new curriculum. When will the speciality exam likely change to take that into account, particularly if we're running a dual two curriculums alongside each other? And And given that there isn't a GIM or a sort of requirement to take a specialty certificate, will there be more acute medicine GIM questions in the palliative one to sort of make up for that? What do we think, panel? You're on mute, Polly.
Sorry, shall I take that as I'm have been involved in the SCE from its inception? Probably the easiest. So I mean, we have looked at the blueprint for the SCE against the new curriculum. It doesn't change massively. I think that it's interesting that a lot of in training that have done the SCE based on the current curriculum blueprint complain that there's too much medicine in it, and that's because it often reflects the section of our curriculum which is around disease process and management, and also management of emergencies, which covers a lot of general medicine. So there's already a fair bit of general medicine in the SCE. I wouldn't envisage that specifically changing, because what we are addressing with the SCE is the knowledge-based component of the palliative medicine curriculum. So it will evolve. It will evolve to better match the new blueprint. But I think that within the blueprint, it will be able to serve both curricula.
Great, thank you, Polly. I think that's fair to say. It's going to be an ongoing work in progress, isn't it? And a lot of thought will be going into looking at the SCE every year, probably even more than recently, if that's possible. That's great, thank you. The next sort of grouping of questions, which sort of stems back to the bit you were talking about, Jane, is to do with the new SIPs. And one of them is, how do we sort of integrate what people have already done who are transitioning to the new curriculum? How do we take into account what they've done and sort of put that into the experience going forward for them? Are there any thoughts about that we've had in how we can help educational supervisors think about that for transitioning trainees? And a similar thing, I suppose, goes ahead for thinking about the experience, people who've say been in ST3 this year transitioning, and the areas that they've worked in. How do we sort of make it count so they're not duplicating things they've already done this year for the new transitioned curriculum?
So I think this will vary on regions. Some regions have educational supervisors that follow trainees throughout all of their training, and some change educational supervisor each year. And I think potentially those that supervise throughout the whole of their training might find this a little bit easier than those that change every year, because what they'll be able to do is look at all the evidence that they have collated up until the point of transition. So that be work-based place assessments, MSFs, MCRs, and what has already been achieved within their curriculum. And some of this, as I said, with the new curriculum, the trainees will need to self-rate themselves as well. And so it is also the trainees' responsibility to look at the new curriculum and see how they feel that they are meeting it beforehand. And it will need to be done really as a conversation in the educational supervisor meeting. So I think for a lot of supervisors, especially for the trainees that are transitioning, over the first kind of year that they transition, there will need to be more meetings to enable that conversation and show how they're meeting things.
Thank you, Jane. I agree. I think it's going to be a bit of hard work, isn't it, for us all? We're going to have to sit down and sort of take an individualised approach. And I certainly know within my own region, very open to supporting educational supervisors as TPD with that too, if we sort of need a second pair of eyes to work that through, particularly in thinking about going forward for ARCPs in the future. Another question that's just come in on the chat, actually, which is relevant to this, it's just about requirements. It's what are the practical procedure requirements for IM? I've sort of popped the curriculum there because I can't remember what the practical ones for IM particularly are off the top of my head. But the other part of the question is, will we have to maintain competence in pleural drains, LPs and other bits and pieces? And I know, Polly, we've had conversations about this to do with our curriculum, particularly with things like the indwelling pleural drains. I don't know if you just want to mention a bit of the kind of flavour of what we're looking at for DOPS and things going forward.
Alistair to answer that question, actually, as it specifically relates to the IM curriculum. I don't know whether you're able to, Alistair.
Thanks, Alistair.
Sure. I mean, the requirement is that once you have shown competency in a particular practical procedure by getting signed off with a summative DOPS, then you do not have to demonstrate your competency after that. It's then a matter of professional probity that you keep yourself up to date with that throughout your training period. So, and then how you maintain that capability once you become a consultant, I mean, it depends on whether you're in a job where you are actually having to do those procedures or not. I mean, you know, I would not, I mean, I'm sure I could, but I would not want to put in a chest drain or do a lumbar puncture now, even though I'm just working as an acute physician, because I haven't done it for so long. So the short answer is you demonstrate that you're capable, and you maintain that capability throughout the training. And then once you achieve your CCT and appointed as a consultant, it depends on whether you are needing to do those procedures or not. I don't know if that answers the question.
Thank you, Alistair. Yeah, absolutely. I certainly know from the palliative curriculum and the DOPS that are going on with that there's certainly an idea that actually it's about demonstrating certainly things like indwelling pleural drains, that we're demonstrating understanding and use as much as we are the actual procedure itself. So it's moved, the idea has moved not just from doing a procedure and being signed off and ticked, but demonstrated that perhaps you've reflected or you've encountered a patient with one and overcome certain problems, and you're doing that on a regular basis to show that you understand how this fits into practice. And I think that's the shift I've seen in the new curriculum myself. Thank you.
Matt, just before you carry on, I know that I saw one hand up, and which was Benoit. I don't know whether it might be easier, Benoit, just to put your question in the chat, because that's how we're doing most of them. If that's
Thank you, Polly. Yeah, absolutely. That'd be really great. If you pop your questions in the chat, we'll pick them up and answer them, I promise. Thank you. Just to reiterate that. Great. Next question I had, which it sort of fits in with evidence moving over, was just about educational supervision. And I think a lot of people have a lot of anxiety about this element and we did go over this a little bit, but I think it's worth repeating really that who takes the responsibility in terms of educational supervision for the GIM role. And Milan, I don't know if you want to just re-elaborate on this bit again, as you covered it in your part of the talk, but yeah. What just highlighting to people about our thoughts about that and how we're going to manage it going forwards.
Yeah, I mean, local discussions I've had in my particular deanery reminded me about this idea of a gold standard in terms of what's expected at ARCP. So the gold standard is separate educational supervision for GIM and separate educational supervision for specialty for palliative medicine. So I would envisage that the TPDs across the regions, I mean, are thinking about their trainees in their separate blocks and then identifying separate educational supervision. So when they're in their IM block, there should be an educational supervisor who is trained in GIM, who can support our trainees when they're doing their IM block. And then the TPD will obviously be identifying the specialty palliative medicine trainers to be educational supervisors for when they're doing their specialty training. So for the time being, I imagine that the large cohort of specialty trainers don't have IM training and therefore are not trained to supervise in internal medicine. So it is a bit about finding the legwork and doing the legwork and finding supervisors for our trainees when they migrate into IM posts. I hope that answers the question.
Can I just come in there?
Yep, we've got Polly then Sam.
I think it goes back to the gold standard. So I think in an ideal world, we would hope that people would have access to supervisors for IM and supervisors for palliative medicine. I think we recognise that that's not necessarily possible to deliver across the board. So what may happen is that when doctors are doing their IM blocks, they will have a clinical supervisor who will obviously help make assessments in the e-portfolio that would then inform a palliative medicine supervisor ultimately making the final entrustment decision, but based on all of the evidence they've gained elsewhere. So the ideal is that you have separate educational supervisors, but it may not always be possible. I don't know, Alistair, whether you just wanted to also come in on that.
Yeah, no, glad to, Polly. And we had a huge amount of discussion about this at the cardiology webinar, which I've just done. So, I mean, it's obviously causing a lot of anxiety to a lot of specialties, particularly those ones where a lot of trainers in the specialty are not practicing in internal medicine. I mean, you can see it's more straightforward for respiratory medicine or gastro or something like that. But for cardiology, where a lot of consultants are not doing internal medicine anymore, and for yourselves, it's obviously more challenging. I think the critical thing is that there are several non-negotiable things. I mean, the first non-negotiable thing is there has to be an ARCP outcome in both internal medicine and in specialty every year. Now, if there's an exceptional year where somebody's purely doing specialty, then obviously that's just recorded in the ARCP. You know, no internal medicine training this year, therefore they don't need an ARCP outcome for that year. But for the majority of the years, they will be doing some internal medicine experience, whether even if it's only a monthly acute unselected take or something like that, they will be doing internal medicine, and therefore they require an ARCP outcome. So you must have 2 ARCP outcomes. In the majority of cases, that would be done probably from a single panel, as long as there are internal medicine, senior internal medicine trainers on that panel. In terms of the educational supervisor, yes, it's a counsel of perfection that you have an internal medicine educational supervisor who is actually practicing in internal medicine, or has at least been trained in internal medicine, preferably still practicing it. However, we recognise that's not possible for a lot of people. And at the end of the day, the educational supervisor is an expert in education, not in the clinical skills and knowledge of that particular specialty. So what they're looking at is whether the trainee is developing educationally rather than clinically. And you're absolutely right, Polly. I mean, what is needed is that to write a good ES report for internal medicine, the educational supervisor needs to have good clinical input, good input from the clinical supervisors. So there's guidance on our website about exactly how many clinical supervisors reports they need from practitioners or trainers who are trained in internal medicine. But it's a matter of the educational supervisor looking at it in the round, looking at what level of capability the trainee feels they've achieved, what level of capability the various clinical supervisors feel they've achieved, looking at workplace-based assessments, multiple consultant reports, multi-source feedback, etc., and then giving an opinion based on all that additional intelligence. So it's great if they do happen to practice internal medicine themselves or have practiced it in the past, but it's not mandatory. What's mandatory is to have that input from all the other supervisors around them.
Thank you, Alistair. Sam, you were going to mention a point. Did you want to bring it up?
It really just builds on what both Polly and Alistair have said. We've just recently had a round of ARCPs in Yorkshire, and for our transitioning trainees, we've had feedback from from their placements, whether it be in ICM or acute medicine, that's really allowed certainly me as a TPD to get a sense of, you know, how they're doing, the confidence that they're building. We may struggle to get very specific educational supervisors in acute medicine, but actually I think it is possible, but it requires the process to make sure that we're both gathering the evidence, and that will be partly incumbent on the trainees, and reviewing the evidence to have confidence. I think the self-rating of them by the trainees of their confidence will also play a massive role in us attributing whether or not we think that there's more that we can do. So whilst I recognise and personally feel some anxiety about it, or have felt some anxiety about it, it's not something that I think is insurmountable. And I think, as Alistair's described it, I think it is possible. It just requires us to think in that way, that we are supporting the educational process, not necessarily having to be experts in every aspect of clinical delivery, and there sign it off on be the individual who's signing it off in that way.
Thank you, Sam. And I think that builds on why the portfolio and why, again, the shift has been to trying to enable trainees to be self-reflective and identify their own needs and communicate that, certainly through the portfolio too, so that everyone can see, you know, at varying points of assessment in that disparate way, so that sort of general medicine, palliative care has a little bit of way of talking with each other in some regards. There's another question just regarding this, which I just think is important because it was probably on everybody's mind, which is there going to be more funding for essentially doubling the ES numbers? Money is always there. My understanding is, of course, that actually funding follows the trainee. So the trainee, it's where the trainee gets the funding. But I don't know if anybody else from the panel wants to just elaborate on that and their thoughts at all.
No, I mean, funding for educational supervision, of course, comes at a training unit level, doesn't it, about being built into job plans. So whilst there has been an agreement that we will be able over the next few years to expand our number of training posts, there isn't direct supervision funding associated with that. But I think that HEE would argue that the funding of educational supervision, it comes with the sort of education monies that comes down to training units, including hospices, and needs to then be negotiated in terms of job plan time to be a supervisor.
Thank you, Polly. We've got a few more themes to go through. We're going to look at patient survey, ARCPs, always everyone's favourite topic, and then just broad experience. So if we just go back to the patient survey, which I think probably causes anxiety for pretty much everybody here, but just thinking about how that goes forward, one of the questions was, of course, number of patients, and Polly, you answered that in the chat. It's actually 15 with an aim towards 30 was what we're doing, and that can include family members. But I certainly know there's been discussion about how difficult getting patient surveys are, so it might be helpful just to touch base about what our thoughts are about the patient survey for trainees and how that fits into the curriculum and how frequently they should be doing a patient survey. I don't know if anybody would like to pick up on that.
Jane, do you want to answer that?
I have a problem with my, can you hear me? Oh, sorry, it doesn't, it looks like the microphone's still off, sorry. So they only need to do one patient survey for palliative medicine throughout their whole training. They do have to do one for IM as well, but that will be in a completely different setting, and so will be separate. It's, as Polly mentioned, it's a minimum of 15, ideally up to 30. And it may be, you know, I think it's really important that trainees try to do this as early on as possible, within a year, so that they've got an opportunity to get feedback within a whole year, rather than kind of leaving it to the last 3 months of a job where it might be quite difficult.
Thank you, Jane. That's helpful. Next question was about ARCPs, really, and there was a good question earlier, just thinking about it going forward, and I'm not sure in the new curriculum that I've seen on the JRC-PTB website that there is an ARCP decision aid grid for the new curriculum just yet, but I imagine that's on its way, unless I've missed it somewhere. But one of the questions really were the summary pages of what's expected at ST3, ST4, ST5 and ST6 that we use are really helpful for people to prepare, certainly at the beginning of the year, and then towards ensuring they're documenting their evidence for the ARCP. Are those pages going to go or change or be updated? And are we expecting, given perhaps that the curricula are subtly different across the, I mean, the curriculum's the same, but how it's been implemented in different regions may be different. Do we think they need changing? What are our thoughts about those summary pages? I think that was the question.
I mean, I think Jane will come in, but I mean, the summary page for the new curriculum, I think would mean that we wouldn't need any additional paperwork that we had developed ourselves as an SAC to support the current curriculum. Would that be your understanding as well, Jane?
Yes, that's right. So I think that there's the minimum number of workplace-based assessments that trainees will need to do, but with regards to, you know, the level that they're at will also depend on which environment they're working in. You know, so if they've never done community before, or, you know, that it may be different to if they've spent a year and a half in a hospice. But also some of that may well be related to how much IM they're having to do in that year as well. So some regions may be splitting their year and doing 6 months and 6 months, and that will still be the whole of their ST5 year, for example. So there's lots of things that need to be taken into consideration at each ARCP.
Thank you. And I think a trainee has just posted in the chat, I think there's some concern that people are a little bit worried that maybe some experience hasn't caught up with the ARCP panel yet, and sharing that. I can certainly say in reply to that myself that as a training program director, I would, if that program was given to me as balanced, then I would be sitting down and looking at your portfolio and discussing with my colleague and coming up with a real pragmatic outcome for the ARCP. And I think just echoing what you say, Jane, that there's going to be a lot of sort of shared learning and a lot of individual looking at trainees over the next couple of years as people transition from their current experience and how they're balancing their IM experience with palliative medicine. One of the questions that I thought would be quite helpful just to answer is somebody's asked that if 3 months of palliative medicine contribute to GIM, then why can we not do just 9 months worth of GIM in the 4 years as opposed to the full 12? Now, my thought about that was that I thought it was because actually your home specialty didn't count, but I just thought I'd ask everybody else and just confirm that.
So, I mean, it's about transferable skills, isn't it, between settings. So if you think about a doctor working in a palliative medicine setting, they're often, seeing new acute patients and managing acute medical problems, albeit with a palliative hat on. So it's about recognition of the transferable skills. So there is quite clear guidance that we have previously circulated from PTB regarding time in kind of parent specialty counting towards IM. What trainees, if they are counting any of their palliative medicine time towards IM, will still need to do is demonstrate that they're contributing towards the acute unselected take over a 12-month period. So again, any discussions about that just need to be done involving the local IM team in the TPD, just to make sure that a trainee doesn't get a surprise at ARCP.
Thank you, Polly. And I think the spirit of the new curriculum is that we're not paying lip service to IM just because we have to, but actually we're trying to make it as appropriate as possible, and that we want people to have key skills and be just as good as any other IM trainee and any other specialty at the end, but individualising that so that individuals, can meet their needs, that they need specific focus and areas on. So I think it's worth noting that that's the spirit that we've entered this dual curriculum with, that we are very much trying to promote both curricula and supporting them both. The next question, next area I wanted to move on to, theme that's come up that's always going to be a hot topic, and I think it's really helpful if we perhaps share some of our experiences, is just thinking about experience and experience of trainees. And the first one that came up really is thinking about the impact on hospices. So if you take one of the models, I think Milan, you showed of how things are implemented, that you have a trainee who's 8 months, say, in an inpatient hospice, or 8 months in palliative medicine, that could be based in a hospice, and then 4 months out in general internal medicine. What are the thoughts on the impact on the service for that hospice and how that's going to impact? And what about the experience need for palliative medicine trainees in terms of out of hours palliative medicine cover? How has that changed going into the new curriculum? I don't know if anyone wants to pick up those points.
Matt, I can talk to that a little bit, based around our experience. I think that we've been very well supported in Yorkshire in terms of creation of our IM placements and the blocks that have appeared. I think how we enable our trainees to continue to have palliative medicine experience while in their medical block, and how we continue to allow them to have acute medicine experience while they're in their palliative medicine blocks, we're working through. In that hasn't started yet because the new curriculum hasn't quite launched, but we feel that we've got a proposal that will allow them to gain and maintain the experience because we've been able to change or alter our posts in such a way that it's not actually going to have any direct impact on our palliative medicine on calls. They will remain the same. And we're also very mindful that we have a range of specialties who are also seeking to do palliative medicine and are seeking to come and spend placement time with us in our hospice settings and other settings. So we've actually been quite proactive in setting up almost like an exchange where we're not really overly concerned about the impact on our on-call rotas, because it's something that we've thought quite heavily about because it was a significant concern. It will obviously be very different in different places, but I think it's something that can be worked through. It just requires that level of working through.
Thank you, Sam. I think that's a very important point. One of the questions that came up, which I think is really interesting, actually, just to give some thought to, is if people are doing their GIM and they want to return to, you know, the warm embrace of doing some palliative locums, would experience or ACATs or work-based place assessments in those locums actually, could they count towards some of the competencies or working towards the SIPs in the new curriculum, and what would our thoughts be on that?
Alistair's going to speak. I was going to say something there. Sorry, Alistair.
No, it's okay.
It's okay.
I mean, the answer is that up until, well, I think there are two important points. One is, I think we all want to be getting away from counting hours, counting patients seen, counting clinics done, counting acute takes done. We've allegedly been in an era of capability, competency-based medical education for about 20 years, and yet, you know, we're partly responsible for this at PTB. I know, you know, people are still counting how many hours somebody's done doing this and how many lumbar punctures they've done and how many acute medical takes they've done. We really want to stress that this is all about assessing people's capabilities, not about assessing what they've done. Having said that, the GMC were largely responsible for a lot of this, because up until about a year ago, 2 years ago, any experience that was gained outside of a UK-based GMC-approved training program could not be, quote, counted towards your medical training. And that, so people who went and did a year in Australia and, you know, did a very intensive acute medical job in overseas somewhere could not use the experiences they gained overseas to demonstrate their capabilities, or else they would have been on a track to a CSER CP, as a CSER combined program, rather than a CCT. Fortunately, that has all changed now. CSER CP no longer exists, and we're no longer particularly concerned about where you gained that capability. It's whether you have gained that capability that matters. So the answer is that if somebody goes off and does locums, be it in palliative or in internal medicine, particularly if they can demonstrate what they've achieved during those locums, and preferably either with a consultant report and an MCR type clinical supervisor report, or some workplace-based assessments they've done in that setting, then if that evidence demonstrates that they are at a certain level of capability, then that's absolutely fine. We do have of course, again, the thing about capability-based medical education is that, you know, you can't define a definitive time that somebody has to spend in training. So you know, the indicative period that the GMC sets is just that. It's the period of time that we think most trainees will need in order to achieve those capabilities. Now, clearly there will be a number of trainees who will struggle with that for one reason or another, be it health reasons or lack of commitment or external pressures. They will not gain the capabilities along the expected trajectory, and they will need to have additional training time, and therefore they will get an ARCP 3, outcome 3 at the appropriate ARCP and be granted additional training time. On the other hand, you will have some trainees who, either because they're exceptionally able, exceptionally committed, putting in extra time, etc., or because they have had previous experience with their palliative care and internal medicine training programs, either overseas or in a UK-based setting. But as a result of those experiences, they will be going through the training program in a more rapid process. And we're just about to publish sometime in the next 2 or 3 weeks. We will be putting on our website the advice as to how those people can be accelerated through their CCT training program. So, sorry, it's a rather long answer to a fairly short question, but the bottom line is,
okay.
Yes, anything like that can be used to show that you've developed the appropriate capabilities.
Thank you, Alistair. That's really helpful. And I think, again, it highlights the spirit of the new curriculum, which is one of a trainee identifying what they feel they need to be improving on or what they've achieved, and discussing with their educational supervisor and really just sitting down and looking at it. Thank you. Polly.
It was just to follow up on that. I think Aruni had put a question in the chat about sort of talking about the sort of specialty on call requirements. And because we're not talking about a time-based curriculum anymore, we're talking about a capability-based curriculum. We've got moved away from what we used to have in the current curriculum around a specific number of weekends. So we don't define that anymore. What we define in the curriculum is the outcome in terms of the capability, the knowledge and the skills that we're expecting our doctors in training to gain, either by working in hospice, hospital or community, or through participation in specialty on call. So specialty on call remains part of the curriculum, but there isn't a minimum number of weekends anymore like we used to have. You will see in the ARCP decision aid for IM, however, that there is a sort of minimum indicative number of patients seen on take as part of that, but we don't have something similar within the Palliative Medicine ARCP decision aid, which does exist. So apologies if it's not made its way to the PTB website, but we will rectify that after next week's SAC.
Thank you, Polly. I'm just going to stay a little bit on experience at the moment because there's quite a few questions that are coming through, and I suspect this does reflect a broader anxiety, none of which I think we can easily solve, but I think it's important that we just talk about it, about gaps on rotas and funding and how that works for people. I think many people are worried that this change is going to mean that hospices that traditionally have had trainees won't have them. One of the questions asked earlier was that given that recruitment this year has been less than it has in other years and that there are many gaps, will we consider going back to the old curriculum again? Now, my understanding is no, we're not going to consider to go back at all. We've committed to going forward, and it's something we're just going to have to ride out at the moment, but I thought I'd open that up to everybody here at the panel for now. And then the next one really is it's just talking about any thoughts about backfilling of money and rotas and trainees. Again, my experience is that is actually quite individual and unique for each region, if I'm being honest with you, and actually one has to go to one's TPD and or region to discuss funding arrangements, simply because I've been trying to work it out for my region, and it's something I think the A team would struggle to sort out. But I thought I'd bring that up for anyone else who wants to share some thoughts and reflections on those 2 points.
Jane, you looked like you were going to say something. Did you want
No, I think, Polly, you're best on the first part about the
rolling back, yeah.
About the fact that we won't be rolling back and the GMC's view. So I thought you should start with that.
Yeah, I mean, I think, you know, as everybody on this, I'm sure most people on this meeting will know, I mean, the moving to a dual training curriculum has not been without its controversy. But, you know, the GMC is, and the curriculum oversight group is very clear that this is the direction of travel for palliative medicine. So we have an approved curriculum and we will be dual training going forward. Amara, I think, is quite right to note that our recruitment took a bit of a hit in round one. That was true for all of the new Group 1 specialties. We are thinking about that quite carefully, planning a bit of a sort of social media campaign and a webinar specifically to target people that might be interested in applying in round 2, which opens in July. And I think that our intelligence is that, you know, perhaps not surprisingly, people are anxious about such a big change to the curriculum, what dual training is going to mean. So I think that, you know, we know that PTB are very committed to working with us to make this change work. But this change has happened. This curriculum is our curriculum, and we need to all work together to try and minimise the impact as much as possible and continue to promote the specialty. I would say that our survey of the training units that we have already conducted demonstrates that already there are lots of gaps. So this is not all about the new curriculum. This is about the fact that we are one of many specialties that has workforce challenges, particularly at the middle grade. And there isn't one answer to that. But what we do need to do is all of us, I think, within our respective services, look at what we need to do to shore up our rotas and our on-call, and that's going to be through probably a mix of different professionals to help deliver that. So trainees are never going to be the only answer to an on-call rota. So I think it is a difficult problem, but I think we all need to work together to think about how we're going to be able to manage our on-call, but alongside that support this change in training. I can see Alistair wants to come in.
Thank you.
Yeah, great. Thanks for that, Polly. I agree with everything you said. And so I don't think there's any way that this change can be reversed now. I think we've been working on it far too long. As say, it has been controversial, as it has in a number of other specialties. But it's highly unlikely that the GMC or anybody else would contemplate us changing back to another curriculum. I mean, in fact, the previous curriculum will be decommissioned as soon as the final trainees have completed training on it. I think one thing to point out is that SIP 8 in internal medicine is all around managing end of life and applying palliative care skills. So we have mandated that all internal medicine physicians have a degree of clinical expertise in managing conditions that are obviously highly relevant to your specialty. As you know, we would very much like to have mandated a period of time for all internal medicine physicians to do some palliative care. And I know that there are some specialties like respiratory and I think renal that are very keen to do that as part of their specialty training. Unfortunately, I think we would not have got away with trying to mandate, a 3-month attachment to a palliative care team within the internal medicine curriculum. But to say it is there in the SIP, they have to demonstrate that they are capable of doing that. And some people could argue that unless they've done dedicated time working with the palliative care team, how can they demonstrate that particular capability? So I think you've got to leave it there as TPDs to be discussing with your colleagues in the local deaneries and saying, look, some of your respiratory trainees, some of your renal trainees, some of your diabetes trainees need to be coming across and doing some time in palliative. I mean, it's going to be difficult because they're all going to be having to do their time on the acute medical rotas, and there's a lot of argument about the service need for medical registrars. I mean, and that's in most Group 1 specialties, trainees will end up probably doing more acute unselected take than they're mandated to do by the curriculum, just because of the service need to stop the acute medicine rota. So I'm not suggesting it's going to be easy for you to persuade your colleagues in other specialties to release their trainees to do palliative on call, but it's certainly, say, you've got a lever there in that SIP 8 of the internal medicine curriculum mandates that people are skilled at managing end of life and palliative care.
Thank you, Alistair. That's a really good point. And I certainly know again from my local area that trying to get reciprocal people into posts has been a challenge that on paper I thought would be reasonably okay, but is much harder than it looks for many different reasons. Jane, were you going to come in on the next point, or Sam, did you want to just reply to that point too?
Yeah, Jane can go first, but there was just an additional thought on recruitment.
Thanks, Sam.
So I think I was going to really answer the part more about backfill and all of that. And there have been so many different conversations that have happened regarding that. And I think it does vary between regions. So we've had discussions with other SACs and local TPDs about certain specialties providing backfill, and the feeling is that no specialty wants to, a lot of the specialties have got reduced time because they're having to do more IM in their new curriculum. And those that don't have more IM, their training time has decreased in time. So they do not want to give up 3 full months to provide backfill in palliative medicine, even if they are going to get the experience for their SIP 8. There are some trainees that would want to spend a month, but then there is all the logistics of trying to get contracts and the such like for trainees to move over for a month, and inductions, and being able to ensure that all of that happens. There have also been a lot of discussions going on with regards to money. So, for example, whether or not the money goes to the hospice, so it doesn't always follow the trainee, but actually if the hospice gets 100% funding, so not all the regions get 100% funding of their hospice jobs anyway, but in certain regions where there is 100% funding to the hospice, they may well be able to keep the money whilst the trainee moves into IM. So that's one discussion that has been going on. The other discussion is actually about trying to increase the numbers as a whole in palliative medicine, so that it also almost that palliative medicine provides its own backfill, because there are an increased number of palliative medicine trainees. So some will be in the same palliative medicine jobs at the same time, and some will be doing IM. Those, I think those discussions are still continuing. And I think there was a question specifically about on-call, and funding for on-call, but I think there is, at the moment, even the 100% funded posts, the hospice pays for their own on-call anyway. So that would have to continue regardless.
Thank you, Jane. Sam?
I suppose in response to the changes in recruitment, yes, there has been a drop, but one of the things I've been really quite encouraged by, and our transitioning trainees might trip me up here and give a different view, but what we've seen is the development of IMT3 posts. We've seen the development of a much greater focus on palliative medicine posts, and I haven't had any drop in interest in palliative medicine training for dual accreditation. Perhaps the people who are approaching me are now maybe a bit different to the ones who approached me before, but there are certainly people who are in internal medicine training who are expressing an interest in palliative medicine training. And so I feel fairly optimistic that this is a lull because of the transitionary period. And, as I'm looking ahead, I see names and numbers of people. Even just today, I was given 2 names of trainees who are interested in palliative medicine. So I think we will persevere, but it doesn't make it any less painful in this moment of time.
No, thank you, Sam. It's a bit of a sting, isn't it? But I agree, we're waiting to see what happens, I think, in round 2 and next year a little bit before we fully have an understanding of certainly the transition's impact, accepting that the last couple of years have been very difficult, and actually attitudes towards training and jobs have been different. And we're going to be, as Polly mentioned, doing various things before round 2 just to impact on that. Thinking about experience as well, there's been a good couple of questions and excellent questions raising the role of research for palliative medicine in the curriculum and the new curriculum. Really, there are some really excellent people and many here who try to raise our research profile in palliative medicine, and given that that we're changing and transitioning to a new curriculum because medicine is changing in general, the need for palliative medicine to have academics and continue to push that forward is absolutely vital. And I guess it'd be really helpful just to hear what our thoughts about the research requirements going forward for the new curriculum will be, and does anyone have any thoughts about academic training and how that's going to go forward? I know, Sam, certainly you have some academic trainees. I don't know whether you have any thoughts about research and training in the new curriculum.
I suppose we've got Steph who's on the call and who described some of her experience in terms of academic training, and I think there is a challenge. I often describe, or when I speak to Steph or others about research, I describe our clinical academics as being triply accredited, really, because they're doing medicine, they're doing palliative medicine, and then they're doing academic training. So that does present its challenges. I think some of that challenge is derived from, again, the transition period and us kind of bedding in. I think there is a sense, I think, from some of the work that's been done around academic training that perhaps academic training needs to start earlier in the process rather than at what will be ST4. And I think we will certainly see that as something that is emerging. And academic training, someone I think has taken over the, someone's email is on there, thank you. I think that it's something that we are proactively working on and exploring. I think I saw, let me just see, I'm trying to see, Amara made a comment, because I think there are clinical academics who I think we will find a way forward, and that it's about us supporting and protecting them and their academic time, but it's about people who are doing academic work but aren't necessarily in an academic post. Will they have the same opportunities for accessing research? I think that's a challenge, but I think it's something that we just need to rise to meet. I can see, Alistair, you've got your hand up.
Yeah, thanks, Sam. Again, I'd agree with what you said. It is a challenge, and again, it's a challenge that's replicated across every specialty, but particularly ones that previously had not done internal medicine and academia. I mean, and again, very similar conversations we've had with the cardiologists about this, because in general, most of the academic cardiologists tended not to train in general medicine as well, whereas from now on they will have to. There were clearly a lot of discussions with the academic medicine community that have been going on, in parallel with the whole development of these curricula, and we've had regular meetings with them over the past 5 or 6 years or more. And it's very clear that there was never an appetite for having a different CCT for academics as from non-academics, and therefore, because the CCT in any Group 1 specialty can only be acquired if you've also got a CCT in internal medicine, the option for single training in specialty alone just does not exist for a Group 1 specialty. So as I've said many times, you cannot get a CCT in palliative medicine from this year without, or once the transition period's over, without also having a CCT in internal medicine. And therefore, if you're training in academic palliative, you have to fulfill the training requirements of internal medicine, palliative, and your academic commitments. Having said that, most of the other stuff about academic medicine hasn't changed. I mean, you can still appoint academic clinical fellows at any stage. You could appoint an academic clinical fellow in palliative medicine at ST2 or 3, and they would do their internal medicine training in over a couple of years, and then have run through into palliative, or you could appoint them at ST4, or, as we've said, a lot of people choose to go off and do higher degrees without actually being formally appointed as ACFs or ACLs. So none of those requirements or none of those opportunities have been in any way affected by the new curriculum. So if you have somebody who wants to go off and do a PhD in palliative medicine, they apply to go UPAR in very much the same way as they always have done. So there's no change to that. I'd say the only thing that's changed is that you have to do general medicine as well as your specialty, and that's a challenge for neurologists, cardiologists, less so perhaps for respiratory and diabetes, who've generally, even the academics have tended to keep up their general medicine training, but in certain circumstances they may not. So it's a challenge for everybody, but the agreement was reached many years ago that there was not going to be a separate CCT for academics, because it was recognised they had to have the same clinical expertise at the end of training as any non-academic, for the very simple reason that a lot of them will not actually necessarily pursue a career in academic medicine, and they're going to be an NHS consultant, and nobody would want an NHS consultant who is less clinically skilled because they come through an academic route. So I mean, I haven't given you the answers, but I've given you the background as to where we are and why we're.
Thank you, Alistair. Now, I'm aware that we're in the last 5 minutes of the session now. Matt, are you back with us to just in terms of whether there was any final questions? No, I don't think so. I think Teams has kicked him out, so apologies to that. So I don't know that we've necessarily been able to answer everybody's questions, but what I'm proposing we do is that we'll go through the chat and try and pull all the kind of questions together and do a sort of FAQs. So hopefully we can put that up on the our palliative medicine page with the PTB on the PTB website in due course, along with the slides from today and the videos from our 4 doctors in training that sharing their experiences. So hopefully there'll be more information there. So yeah, if you go to the palliative medicine page on the PTB website, hopefully that will in due course be helpful for you. I mean, this is, as I said before, this is, you know, obviously it's a very big curriculum change. We do anticipate it won't be completely plain sailing, and you've already heard that from the trainees, that there are some unintended things that come up that we will need to address as we go along. So I would just ask you again just to make sure that you're working closely with your training program directors in all of the different regions. Please escalate any issues, concerns, problems as soon as possible so they don't escalate. And I'm hopeful that we will be able to get this working smoothly in the not too distant future. So thank you all very much for coming, giving up your Tuesday lunchtime. We're really grateful. Thanks again to the trainees and Alistair.
Yeah, if I just say in closing, thank everybody for coming to this and showing the interest and the, you know, all the positive way that all the questions have been framed. I think it's been shown that there is a real appetite for this change. Obviously, I'd like to thank all our team at PTB, Vicky and Zoe and Isabel and all our colleagues who've worked really hard on this, but above all to thank the SAC in palliative care. Polly has been fantastic in, you know, just the flexibility that everybody's had and the enthusiasm that people have had, and all the colleagues on the panel today. It's been a fascinating journey that's taken a long time, and it'll be amazing to see how it develops. But you know, it's been a great specialty to work with. So thank you to everybody for making life easy, well, easier than it might have been.
Well, thank you, Alistair, and thanks also to my colleagues on the panel. All members of the SAC, and outgoing Jane, but thank you anyway. So yeah, please escalate, and good luck everybody. Thank you very much indeed. Thank you. Bye-bye.
Thanks.